Hello, and welcome to another honest conversation with HSJ. I'm Ollie Hudson, Content Director at HSJ, and today I'll be talking to Nicola Ranger, General Secretary and Chief Executive of the RCN. Nicola will be joining us at the Patient Safety Congress on the 15th and 16th of September in Manchester, which she's agreed to talk to us before about some of the big themes in her plenary speech. Nicola, could I ask you first of all, let's start on a positive note. What's your strongest case for investment in the workforce right now when budgets are tight and productivity pressures are rising?
The most important thing to patients is to have a really skilled and brilliant clinicians working with them. And actually, the constant presence for many patients are nurses, particularly registered nurses. And if they're not skilled, if they're not brilliant at what they do, genuine patient safety genuinely does suffer. And I think at the moment we can't afford not to have brilliant clinical staff, particularly nurses. And this isn't just about the volume of people, it's about the skills that they have. And it's also the environment in which they work in. And it's a personal view. I think at the moment, whilst we have systems, some of those systems actually stop people being bold and brilliant because we are developing quite a risk-averse clinical decision makers. And in the end, we make patients more unsafe as a result.
So how can we increase clinical capacity? How can we get the NHS to increase clinical capacity without compromising patient safety or quality care in this environment?
I think we need to genuinely look at our skill mix and look at the volume of people we have, the roles we have, and really look at what are people's function within that team, and not be protectionist around position, but think what do patients need, and because at the moment we've developed lots of new roles actually.
Mm-hmm.
But actually, what's the real added value? We think we need to be honest about that. And how does each profession genuinely make patients safer? Because actually, sometimes we've got to look at how we're spending money and think, do we need to reduce the number, but focus on a greater skill and greater volume in other areas? Because I worry at the moment that we put lots of roles in that we think make things better, but in the end, are they?
Can we talk about the three shifts? So how do you see nursing leading these three government shifts that Wes Streeting talks about: treatment to prevention, acute to community, and analog to digital? Isn't that at the heart of it?
It is at the heart of it. But I think it's about making sure we have got the right skills. So if we take analog to digital as a start, a lot of the people really leading those innovations at the moment, if we're really honest, are our fantastic medical colleagues. But actually, real nursing innovation to free up nursing time, to free up their capacity, we're not seeing I don't think nurses are enough at the table in this space. If you look at what nurses spend much of their time doing, it is about risk assessment, striving to keep people safe. You know, lots of falls assessment, must scores, safeguarding assessments, all sorts of assessments that are very similar, but take a lot of time. What you're really trying to calculate is patient safety risk. There's got to be a clever way with 5 key questions within an AI tool that properly calculates potential safety risk for patients. That's where some of the real advances will be. That will liberate nursing time and actually give them more time with patients. But we're not talking enough around those kinds of AI and technological advances for nurses. And particularly, talk to district nurses, multiple logons, equipment that doesn't work, all sorts of things. As well as looking at the fancy, the future, we've got to get the basics done in hospital wards and community settings and GP practices. When it comes to prevention, the people I believe that are really, really well placed to have good conversations with patients are nurses, actually. We talk about prevention as if it's a very easy thing to do. You're having pretty intimate conversations with people about their lives, actually. You've got to have the right setting. You've got to assess the patient. Are they ready to have some of those conversations? If you're talking to somebody about their alcohol consumption, what they eat, what they drink, what they smoke, those are pretty invasive conversations, actually. And actually, you've got to have the right setting in the right place. And I think that's why nurses, particularly in people's homes and GP practices, are really well set up to be able to have those conversations. But we need to liberate their time so that they will be able to do that. And when it comes to that sort of left shift out of hospital, we've been trying to do this the entire time I've been a nurse, which is a very long time. The time for talking is over, genuinely. The public are losing faith in the NHS. Patient satisfaction is at the lowest it's ever been since we've been measuring it. And more people are looking for private healthcare than they ever have. Why? Because corridor care, far too many patients in inappropriate settings. I've met patients who spent their entire hospital stay sitting in a chair, 72 hours. That is a form of torture. And that is the current way that some of our patients are being treated in hospitals. If we don't get that 30% of patients that don't need to be there out of hospitals, I think the public's going to lose faith with us. But how are we genuinely going to do that? We really haven't ever really landed that looking after people in their own homes at scale with the right workforce, with the right infrastructure, and really with the right sense of autonomy for patients, and trying to be really honest with the public around, what sort of care do you want? Do you want to be, how much treatment do you want? I mean, we know that the majority of healthcare admissions are in the last year of someone's life. We need to start having really honest conversations and people-led conversations around those things, and that will genuinely start to move that left shift. It is far braver to make a clinical and patient partnership decision to keep someone where they are than keep scooping them up into hospital. And actually, I think we've got to start being braver and stronger and really start respecting patient autonomy rather than worry about having a decision that will be criticised in retrospect. And that goes back to what I said at the beginning. If we want to do more with less, we've got to genuinely start having braver, more clinically patient-led decisions than we currently do. Because I think at the moment, a lot of our decision making is quite defensive because we're worried about potential criticism in the future. And I just don't think that's the right thing for what we're trying to achieve for patients.
We're just staying with this idea of doing more with less. What are the risks here?
I think we've got to be really honest about there are some things that we absolutely cannot do without less of. Actually, we learned that from mid-stamps, or we should have done. But we're not. We're potentially once again falling into that trap. There are some things that we absolutely cannot have less of. And one of those is nurse staffing. That was one of the key findings of the Sir Robert Francis review. But with this summer, a focus on finance, nursing being the largest workforce, once again, we are potentially looking at how do we reduce nursing numbers. Now, I've been assured that is in frontline clinical areas, but we need to wait and see on that, actually, because there are some things that we absolutely cannot do without less of. And one of them is the nurse staffing the closest to the patient. So there are some things that absolutely should be ring-fenced. And some things we may be able to do more with less of, but we've got it, if we're serious about patient safety, there are some things that should not be up for grabs and should absolutely not be compromised on.
So final question, Nicola, what practical strategies can safeguard healthcare delivery and morale during this period of rapid change and transformation? Maybe you could talk about morale in general.
I think we talk about putting the patient at the centre. I'm not sure we always do, actually. I think if you look at nursing, do we really invest with the skills and expertise to that nurse or clinician that is closest to the patient? And actually, I think it is time that we genuinely put the patient at the centre. And I know that's in hospitals, GP practices everywhere, but if we were to look at hospitals at this moment in time and did a 2 a.m. check on the skill mix of our workforce at 2 a.m. in the morning, I think we'd be shocked, genuinely shocked. And actually, if you look at nursing, that's a 12.5-hour shift. That means half of the patient's stay is on minimum staffing. That's the reality. Half of that 24 hours on minimum staffing. So we talk about being patient-centred. We talk about being safety-driven. Would you really run a service the way we do at the moment in a hospital with that real skill mix, with the most junior people on at 2 a.m. in the morning? I'm not sure that's that patient focused. If you look at keeping patients well at home, either coming out of hospital, stopping them getting in. If you look at a district nurse, which I've met district nurses on 15-minute intervals per patient because of sheer workload demand, is that really safety critical or patient focused? I think it's time that we had some really honest conversations with ourselves and the NHS and say, this is how we've always done it. Is this the right way? Would you really run a health service that puts the patient at the centre, how we are currently doing it? And I'm not sure we would. And I feel strongly about that because I spent just under 5 years in America, and that is not the way they would run it, with that really high skill mix of very junior people at 2 o'clock in the morning. So I think it's time to rethink this.
Nicola Ranger, thank you very much for joining us. This has been an HSJ Honest Conversation. Goodbye.